This is Wayne Eskridge. I'm the founder and CEO of the Fatty Liver Foundation. And I'd like to welcome you to our webinar series. This is a retrospective on the EASL meeting that just took place in Europe. Patients often don't get to go to these big meetings. EASL and the AASLD are very large gatherings of doctors and researchers in the medical profession where they talk about all the advances and what the state of the art is with liver disease. And we thought we'd provide a window to you because you are interested as patients and the people that care about this to give a little sense of where the state of the art is. Next slide. I'm asked why I do this from time to time, and the simple answer is I'm a cirrhosis patient, and I do this to save my life. When I was diagnosed, I heard the words, "You have cirrhosis and we have no treatment." And of course, the thing you do when there's no solution is, well, I'll help you make one. So next slide. We have to do a little bit of housekeeping here. Could you go back one, Henry? The lawyers talk to us about the things that we can say. We're going to be talking about things that aren't necessarily approved yet. We may use some words that aren't typically available in the patient communities. So be aware of that. And also, this is not in any way medical education for you. Do not use this as instructions on how to manage your health, and no doctor-patient relationships of any kind are established. So thanks. Hey, next slide. Just to give you a sense of the state of play here, one of the problems we have with liver disease is that people don't know about it. People don't know NASH when you say it. And one of our challenges is that it's so common. It's as common as dirt. Nobody talks about NASH because it's become almost the norm for our society. About 100 million people in America have fatty liver disease. So that might not be you, but if you have two friends, one of you has a fatty liver. So you probably have it in your family, certainly in your friends. You know people that have this situation. And most of them don't understand it as a potential risk or a disease. In the more serious form, it's called NASH, and that's when liver cells actually begin to be damaged and you start to have fibrosis, that's scar tissue forming. About 20 million people have NASH, don't know it. We have more serious forms. When NASH gets to its symptomatic phase, we call it cirrhosis, and that's where I ended up personally. And about 5 million Americans have NASH, cirrhosis, and don't know it. And that's a pretty scary thing because it's just no darn fun to have advancing cirrhosis. Next slide. So very few liver patients actually see their biopsy slides. I had gallbladder surgery in 2010 and my surgeon didn't like my liver and he took this biopsy. And one of the interesting problems we have with our medical care today is that liver disease is not particularly looked for. It's not diagnosed well at the primary care level. So I had this slide, but all my tests, all my blood tests were good. So the doc, my gastro doc said, there's nothing wrong with your liver. You don't need to come back, and sent me away. Next slide. I went for 5 years, and then I had another biopsy. So you don't have to be a doctor to look at that and say, wowsy, that's entertaining. That blue is scar tissue. That is classic cirrhosis. And I was very close to being in real trouble here. But I got, next slide. And let me explain the thing that makes me so unhappy about this experience, because you see those little blue lines? That's baby scar tissue, and that's early stage fibrosis. Any doctor today would look at that and say, well, you know, you need to do something about that. But I was sent on my way, and I spent the next 4 years becoming dangerously ill. Next slide. But we got good advice. My wife and I did what we were told to do. We changed our lifestyle. We took a new diet. We took on more exercise. And over the next 18 months, I actually made a huge amount of progress with managing my disease. I was a reasonably far advanced stage 4 when we started, and today I'm a stage 3, high stage 3, which is not without risk, but it's far more manageable than being a cirrhosis patient looking at end-stage liver disease. And all of the things that we did in our diet are on the right there, but I won't go through those. You can catch those on the website. So next slide. So we created the foundation and we want to improve various aspects of liver disease, the diagnosis, treatment, and support of people that have it. Next slide. And oddly, you wouldn't expect this to be true, but we're the only national patient voice dealing with NASH on the ground. It's important to understand there's a distinction. There are a lot of people talking about NASH. There are a lot of people talking and writing and advocating about liver disease and fatty liver disease and NASH. But our goal is to be down in the mud and the blood where the patients are. Our goal is to be involved with patients' lives with the screening that takes place and guiding them into care. So it's a lot harder to do that than it is to advocate for policy and to talk about all the things that are wrong. So next slide. The areas that we think we can make a difference are in communications, the kind of public outreach that a lot of people do. Screening is the part of the program where we actually get to touch people and work on the disease part. We're patient advocates to government and so on. And we talk a lot about lifestyle. We try to pass on those things that we've learned in our journey so that other people don't have to go through what so many people do. Next slide. So I'd like to introduce you to our moderator. This is also our Chief Medical Officer. It's Dr. Mistry. He has a long history with HIV and Hep C, and he's run several nonprofit organizations. He's a public health expert, and he's a professor at Georgetown teaching about public health. And Raj, I'd like you to take it away.
Thank you, Wayne. And I've heard your story many a time now, and I have to say it's always inspiring to hear, and particularly to see the reversal of the condition that you had through lifestyle interventions. You know, coming onto the Fatty Liver Foundation, a patient advocacy organization, was an interesting experience, and it's reflective of my journey as a physician and care provider. In that there was a turning point when I became a patient advocate. And the reason behind this is when I started working with patients, what I realized is if I didn't see medical conditions from the patient perspective, it was very hard to get true healing. And so it's almost understanding it from the demand side, not just the supply side that we provide as carers of patients. And so that's the perspective that I maintain today, and it ties in well with my work in the Fatty Liver Foundation. Next slide, please. So what I wanted to represent was fatty liver disease and NASH in terms of how we see it from a public health point of view. And we're just going to sort of go through this spiral starting from the outside. So what we know is that when it comes to the health system, we're not well equipped to actually deal with fatty liver disease because it requires a multidisciplinary response. It's not just a medical issue, a scientific issue. It's a sociological issue. It's a lifestyle issue. We know that the distribution correlates strongly with socioeconomic disparities, racial distribution, ethnic distribution, etc. So in order to address this from a public health point of view, we have to take all these factors into consideration. In addition to that, as a medical condition, we don't have a medical intervention for this. And so the response that we mount to fatty liver disease and NASH cannot be limited to the medical intervention like we have for other issues with vaccines and drugs, etc. In addition to that, we know that if we don't take preventative action, if we don't curtail behavior and try and reverse this issue, we're going to have to get to a point of managing much more expensive interventions. And it's estimated that NAFLD and NASH is going to cost $103 billion in the United States at some point. And NASH is also the 21st century's looming public health threat. And if you look at that and sort of keeping in with the analogy of the storm, we have a convergence of many storm systems to produce a superstorm. And those many storm systems are the epidemics of obesity, diabetes, metabolic syndrome, high cholesterol, the increasing inactive lifestyles that people are leading. And the liver is the point of convergence of all these particular issues manifesting as fatty liver disease. So it's almost the perfect storm when it comes to various issues that we're experiencing on the health side. And that's going to result in being the leading cause of liver transplantation in 2020. And that what we call the tip of the iceberg, where the number of presentations are just going to be a small proportion of people actually living with the disease. Something else that we found challenging from the medical point of view as patients, and Wayne's story reflects this, is there isn't sort of general consensus on how we stage this, how we manage this, etc. And what we found interesting also is that while hepatologists are very well versed in this, primary care physicians are not. And generally that's the first point of call for any ill health for the patient population. So there's not just education and awareness that we need, among the general public and the patient community, but it's also something that we need to do within the medical community outside of the hepatology discipline. Next slide, please. And this is the tip of the iceberg that we talk about, where we have a sense of 180,000 patients that are diagnosed with NASH. From that, we've managed to get 3,000 patients into trials. And because of the high failure rate, that is the number of people that we screen and try to get into trials is so small. What our concern is for as patient advocates is that to develop new therapeutics, we're going to have to get more patients into trials, which means that we're going to have to screen and diagnose more patients. And this is the frightening statistic that over 100 million Americans who are unaware of their status of having NASH or fatty liver disease are walking out there with this pathology, but not aware of it. And so this is what we need to do to raise awareness and then start screening programs. And to that end, the Fatty Liver Foundation piloted the SUN-1 study. The next slide, please. And this was to actually prove that we could find these people. And I don't want to say they're patients because they weren't presenting with any illness, but they had this pathology in them. And so the SUN-1 study was an observational and screening study that was done in the community. It wasn't done through health facilities, but literally taking a portable FibroScan machine and going out and screening populations. And you know, there's an old saying when a bank robber was asked why he robbed banks, he said, well, that's where the money is. And so that's what we did. We thought if we want to find patients with fatty liver disease, we have to go to those communities that have high prevalence of these diseases. And in those communities, we actually found 80% of the population that we screened, an enriched population, actually had some sort of fatty liver disease, of which there was 20% that had NASH. And so what we're planning to do now is replicate that model, expand it and scale it up. And for the SUN-2 study, which we've already drafted the study proposal, we're looking at screening 20,000 patients. And one of the really important things that happened along the way is what Wayne calls the teachable moment. And across all health programs, what we found is that when someone gets the diagnosis through a test or a screening intervention, it actually changes their behavior, either to seek medical help or to actually change their lifestyle. And so that's what we're excited about now to scale up the screening program. Okay, so, next slide, please. So without much further ado, I'm delighted to welcome our esteemed panelists, and I'll introduce them one at a time. Each will be speaking on a different area. Dr. Gunn will be speaking on lifestyle and diet. Dr. Tetri will speak on testing, and Dr. Friedman will speak about treatment. I want to note that they will be reporting from some of the outcomes and presentations at the conference at EASL. So they won't be doing a comprehensive overview of where treatment, etc. is, but rather what the cutting edge research was at the conference. Next slide. So Dr. Gunn is the adjunct assistant professor at Texas A&M College of Medicine. She's a physician investigator, and she's a gastroenterologist and hepatologist with Pinnacle Clinical Research, and so based out of Austin, Texas. So welcome, Dr. Gunn, and look forward to hearing your presentation.
Thank you, and it's a pleasure to be here this afternoon, and I'd like to thank you and the organizers at Fatty Liver Foundation for inviting me. Next slide. These are my disclosures. Next slide. And we're really going to take a deep dive into diet and lifestyle. We know that with fatty liver disease, the foundation of treatment is exercise, diet, weight loss. And although we're very desperate to find a medication that can ultimately treat fatty liver disease, we know that diet and lifestyle is certainly going to be a critical piece of the treatment paradigm. The current recommendations, as you well know, are interplay between physical activity, diet, some structured programs, and lifestyle interventions. But patients often ask, well, what should I eat? How should I eat? When should I eat? How do I lose weight? And we really don't have a specific answer to those questions. And what I'd like to share in the next few minutes are some of the studies that were done from the European Congress and talk about some of the dietary recommendations. So next slide. So I chose 3 abstracts or studies, and we'll talk about it. And I really am excited to be speaking to a patient group, because we'd like to hear your feedback on these studies and what things may have worked for you. So the first abstract we'll discuss is one that just talks about carbohydrate restriction. The second is Mediterranean diet. And the last is general lifestyle intervention. Next slide. So the first abstract or study that was presented is titled Carbohydrate Restriction Reverses Non-Alcoholic Fatty Liver Disease by Altering Hepatic Mitochondrial Fluxes in Humans. And that's certainly a mouthful of information, but I hope that I can simplify it so you can understand what was pulled out of this study. So we know that carbohydrate restriction has really become a fascinating topic, and it's a dietary intervention that seems to do really well in fatty liver disease. But what we don't understand is what is the mechanism, what's happening on a cellular level that's driving this fantastic result when people reduce their carb intake. And so the aim of this particular study was to really look at that mechanism that carbohydrate restriction affords to fatty liver patients by using a really novel technology called PINTA, P-I-N-T-A. And that stands for Positional Isotopomer NMR Tracer Analysis. And essentially they'll infuse patients with tracers that target molecules within the liver metabolism. So they took 10 overweight, obese adults who were otherwise healthy. The average age was 58. The body mass index was on average 32. Again, these patients were obese or overweight. And there was an even split between males and females. And they assessed their liver fat and stiffness or elastography between using MRI technology, and again, using that PINTA method to measure the different molecules in the blood. Next slide. As a result of this reduced carbohydrate intake, first, let me describe what differences there were. So of these 10 patients, they were put in a very rigorous 6-day diet that was reduced in carbohydrates. Before the diet, these patients were accustomed to eating well over 180 grams of carbs a day. But during the diet, they were reduced to 23 grams of carbs per day, which is about 6% of their dietary intake. And their calories, in turn, were also reduced, where before the diet, the patients were eating well over 2,000 calories a day, and during the diet, it was reduced to 1,400 calories per day. And if you focus your attention to the table on the bottom left, you'll see that they were able to assess various things. So they checked the beta hydroxybutyrate in the blood and the acetoacetate in the blood, and they found that those were increased 10 and 6-fold. And what that meant was, one, that the body was entering ketosis, where fat was being used as fuel. And it also told us that the patients were actually compliant with the diet. They were eating the foods as directed. The other thing that we saw was body weight was reduced by 3%. Also, glucose and insulin concentrations were reduced by 22 and 53%, which tells us that there was some mechanism with carb restriction that had an impact on insulin resistance, which is very much a part of fatty liver disease. Many patients with fatty liver disease have underlying diabetes or prediabetes. And most importantly, the liver fat was reduced by 31%, which is why we're all here. We're all here to discuss getting rid of fat out of the liver. And what the researchers were able to derive from this study was that the reductions in liver fat were very well attributed to, again, the ketosis, the breaking down of fat and using it as fuel. These fats were disposed of, and that certain enzymes that help facilitate the liver's own ability to make fat were now reduced. So this very complicated figure at the bottom right is essentially saying that carbohydrate restriction does something on a cellular level which pushes the body into ketosis, reroutes the way the body or the liver handles fat, and avoids the mechanism by which liver will make fat. Next slide. So the take-home messages are that diet does matter in fatty liver disease, and we're still trying to glean what that best choice diet is. But this study does help us to see that when we tell our patients, hey, you might want to consider reducing your carb intake, there's a reason for that. There's a cellular explanation to that. What we couldn't quite tell from this study was whether it was a low carb or a low calorie diet that really facilitated these changes, but certainly something to discuss. More studies are needed. So now let's move on to another study. Next slide. So this study focuses on the effectiveness of the Mediterranean diet versus calorie restriction in non-alcoholic fatty liver disease. We know patients want to know what to eat, how to eat. And the Mediterranean diet, if you're not familiar, is one that's enriched with plant-based foods, fruits and vegetables, nuts, seeds, legumes. There's some moderate protein and dairy, but the protein mainly comes from seafood and shellfish. So the question was, is a Mediterranean diet more beneficial than other diets in fatty liver disease? And this was a systematic review of over 2,100 publications that were answering questions specifically to diet and fatty liver disease. So the researchers used a series of databases. They entered information about diet, fatty liver disease, Mediterranean, low fat, low carb, low calorie, and they put them into a database to crunch out information. And so what they were able to find were 15 trials, over 1,700 patients included. 59% of them were male with an average body mass index of 30 that were compared over a course of 30-week follow-up. And they compared standard of care, calorie restriction, and Mediterranean diet. And standard of care really is casual. That means a patient comes to see their doctor, the doctor says, hey, you need to lose weight, I'll see you in 3 months. That's just a casual conversation, and that's considered standard of care. So these are the results that were gleaned from this trial. The Mediterranean diet seemed to be the diet of choice with or without the amount of weight that was lost. So when they compared a calorie restricted diet versus standard of care, they showed that there was some improvements in the liver enzymes, namely the ALT, which is specific to liver. There was improvement in liver fat as measured by various modalities, and there seemed to be a higher weight loss, as you can imagine, with folks that were prescribed a calorie restriction versus those that were prescribed standard of care. Then, when they looked at the Mediterranean diet versus standard of care, there seemed to be a higher weight loss associated with the Mediterranean diet at 5.7% versus standard of care at 1.1%. And there was also a higher fat content decrease in the liver with those who were prescribed a Mediterranean diet. And lastly, they looked at the Mediterranean diet versus a low-fat diet and showed that although both seemed to improve the liver enzymes or the blood tests regarding the liver and the liver fat content, it seemed that the Mediterranean diet caused a higher liver fat decrease regardless of the amount of weight that was lost. So next slide. So although this was just a review of the data, a review of all the literature that correlates with fatty liver and Mediterranean diet, it does seem that when we recommend a diet for fatty liver disease, it may very well be a combination of what the Mediterranean diet includes with calorie restriction, maybe some carb restriction. We really do need to do more studies to understand why maybe the Mediterranean diet constituents might be preferential over other diets, if you will. But it certainly is something that we can share with patients about how to change their eating. Next slide. And the last study that I'd like to present, I think was a fun trial in my mind, because it really is going to help us, especially in this platform as we're discussing with patients how to eat and what to do. This was a nice study that really looked at what the response was to a multidisciplinary lifestyle training program in a community in the United Kingdom. The title of the study was Direct Access Lifestyle Training, Improves Liver Biochemistry and Causes Weight Loss, but the uptake is suboptimal in patients with non-alcoholic fatty liver disease. So the question was, what is the uptake on lifestyle training and what impact does it have on patients with fatty liver? So what the researchers did is they identified 167 patients with fatty liver disease that were referred into primary care. And they offered these patients a one-on-one lifestyle trainer, once a week visits, close to the patient's home, fully funded. They didn't have to pay for anything. It was a 12-week program, and the average age included in the study was 58. So remember, I said 167 patients were offered this opportunity. Only 16 patients completed the program. That's 1 in 10 patients. The weight loss was, of course, greater in the intervention group, where the people who followed the program and completed it as scheduled lost 2.79 kilograms versus those who didn't, which lost on average less than 1 kilogram. They found that those who completed the intervention group had a higher quality of life, higher emotional well-being compared to the others. They increased their fruit intake by 61%, decreased fried food and snacking. The liver numbers, ALT, and cholesterol numbers did not seem to change over that 12-week period, but it was a short study with a small number. Next slide. So there were a small number of patients who participated in the intervention, and the authors were left scratching their head as to why, when you provided everything that the patient needed to do the only thing we know that works, at least at this point, in fatty liver disease. So it's definitely something we should talk about later. But we do see that maybe a supportive, multidisciplinary intervention where we include nutritionists, patients, physical therapists, personal trainers that can help support our fatty liver disease patients could yield some really good positive outcomes. And again, the study was very small, so we couldn't really assess lab changes, or they couldn't assess lab changes. We do know from other studies that really aggressive lifestyle treatment does cause changes downstream in blood values and the like. But we do want to be able to offer our patients a multidisciplinary tool for fatty liver disease management. I thought this was a nice study to share. Thank you. That concludes my presentation.
Dr. Gunn, that was excellent. Thank you. And you certainly made it understandable for us. I'm just going to kick off with 1 or 2 questions, and then we'll go to Dr. Tetri, and we'll save some of the questions coming in for the end. So as the general public, we inundated with a new diet almost every year or every 2 years, right? And there's almost like a fad-like marketing quality to it. So I know these studies focused on the Mediterranean and a calorie-restricted diet, but from the off-the-shelf, so to speak, diets available, and we're hearing about it all the time, the ketogenic, the paleo, the Atkins, and the Mediterranean diet has come in and out over the years. What recommendations would you make to patient and public communities to navigate through all of this with all this disparate messaging at times, based on the studies that you've talked about and your knowledge?
It's highly overwhelming. I'm going to agree for sure with that. There is a lot out there, and people want to get what's sexier, what's hot. But I think it's really what's going to be sustainable for that patient. Is a ketogenic diet work? Does it work with your lifestyle? Is it something that you can see yourself doing long term? So I think there are a lot of qualities in all the different fad diets, but if ultimately it causes weight loss for a particular individual, then that's the diet for them. So, but in general, when I counsel my patients, I often like to say, if it's white, it's not right. And they take that home. They look at their plate, and here in Texas, tortillas line the streets. So we have to really be careful about tortilla intake, bread, pasta, rice, and those things. So I do advocate for a lower carb diet, an enriched fruit and vegetable diet. But again, taking different features across all fad diets and making sure it's applicable for one's lifestyle.
And then and you alluded to this certainly in that last study, it came up, you know, tomorrow, if we have a medical intervention or we have a proven diet that works, etc., at the end of the day, that those technologies are as good as the adherence and compliance. And how does the medical and scientific world now approach the support that we can offer the patient community to ensure adherence and compliance to diets, to medication, etc.? It's a big question, but you know, you've alluded to this.
I think we have a lot of work to do. I don't think that we are armed with the resources that we need to ensure that patients have what they need to be adherent to a program. Again, just like that one study, the standard of care is a casual conversation about weight loss with your patient, and then you see them back in 3 or 6 months with nothing. You give them nothing. So I really, my hat's off to some of the programs that have developed a unit, a fatty liver unit, where there are multiple disciplines to include nutrition, dietitians, physical therapists, personal trainers, because these patients often have other medical problems and they need multiple specialists involved to ensure their success.
That's great. And when we talk about diets, we definitely talk about it in a more holistic way, like a lot of things that one has to eat. And in the spirit of if it's white, it ain't right, or not choosing your food, we do have a question about sprouted brown rice. And you know, people are always looking for one thing, but that might change anything. Is there any data on this, on reversing NASH?
I'm not sure about data in reversing NASH, but we do know that if you're going to choose a carbohydrate, make it be one of the more complex ones. But again, rice is rice, bread is bread, pasta is pasta, whether it's brown, black, or otherwise. So we do want to really drive in that message that you really have to cut the carbs. But if you're going to choose a carbohydrate to eat, ensure that it's enriched with fiber, which makes it brown, of course.
Okay, excellent. Well, we'll come back to further lifestyle and diet questions at the end. But I'm delighted now to introduce Dr. Brent Tetri. He's the professor of internal medicine and the director of NASH studies at the St. Louis University School of Medicine. And he's coming to us from St. Louis, and he's going to be talking about testing. And, you know, from all my work that I've done, we always talked about testing being the critical nexus between prevention and treatment. So we're looking forward to your presentation. Over to you, Dr. Tetri.
Well, thanks, Dr. Mistry. And first of all, thanks, Wayne, for your passion and your commitment to all the efforts you've put in, just to put this webinar together today. We really appreciate the work you're doing in the field. And Dr. Gunn, great talk. I missed the talk about the Mediterranean diet versus low carb, but that was, you know, because I was paying attention to other talks. So I'm glad you reviewed that. You know, and I often talk to my patients about Mediterranean diet as a reasonable choice because there is data supporting that. The other one, just an aside, one comment I'll make is, you know, we say diet, we're talking about just generically what people eat when we use that word. What I never do when I talk to patients is I never tell them to go on a diet. That has a lot of baggage with it. It implies denial. That's something you want. And there's a lot of literature on the psychology of denial. Our brains are hardwired, as we all know, we all feel this. We're told to do something. What do? We don't want to do it. And same thing with a diet. You know, if you're told not to eat, you know, whatever, or you're told to, you know, you got to limit your diet to certain things, then you just focus on, you know, the restrictions. And what I tell my patients is just to focus on healthy eating, and that's Mediterranean diet, you know, normal portion controls. You go to restaurants, you split portions and all that. And I think it's a rational approach based on human psychology and just dealing with the way our brains are wired. So I always encourage people to do that and acknowledge, you know, sometimes we screw up and we eat the donut or whatever. It's like, okay, you did that, so what? Move on. focus on healthy eating. That's just on a little aside there. So I'll advance the slide there, and I'll talk about testing. You want to advance the slide, please? Thank you. Disclosures, just a comment about disclosures. We all have them. We all do a lot of consulting with different companies as they try to develop testing and therapies for NASH. It doesn't mean we're in the back pocket of these companies. In fact, more often we're giving them the negative comments about what they're trying to do than positive. So it's a mixed bag. So next slide. Let's talk a little bit about the biopsy, okay? Many of you may have had a biopsy or been told you need a biopsy. What do we see on a biopsy? So here are two different types of stains of biopsies. So a biopsy, a little bit of liver is obtained from the liver, a little bit of tissue is obtained and put on glass slides and really thin slices. And just to orient you here, the total height of these, I would estimate to probably be about a millimeter or less than a 1/16 of an inch. Okay, that's from top to bottom on this picture. So if you imagine shrinking each one of these images down to less than a 1/16 of an inch or about a millimeter, you can appreciate these findings are all very small, and that's why we need the microscope to look at them. The little white blobs you see on both sides, that's the fat buildup. That's the fat buildup in the cells. And that's associated with the damage that we see as ballooning, where some of the liver cells just get very enlarged. They're probably starting to die is what happens. It's the last stage of death for that particular cell. In a response to the inflammation that goes on and the cell death, the body's response is to form scar tissue. And that's where Dr. Friedman's on the call, and he has spent his life understanding this and moving the field forward in enormous advances to understand why that scar tissue develops. In the stain on the left, it's sort of stained in a turquoise bluish stain. That's called a Masson trichrome stain. And it'll pick up the collagen or scar tissue nicely. And you can just see how it's spread around. We usually see some around blood vessels, that's normal, but we don't see it interspersed in the liver as Wayne showed in his biopsy. So that's the biopsies, a little bit of the information that we get off of that. The pathologists or the doctors who look at these slides and make a career of it see a lot more information on here and really can convey to us a lot more than is typically described here. So I still find biopsies useful at times, but I'm doing a lot fewer of them because I do a lot more other testing. So next slide, please. So, identifying who has NAFLD, and especially who has NASH, is a challenge. In terms of symptoms, about a third of my patients, we did a survey once, have a little bit of right upper quadrant abdominal pain, and where the liver is, it can be sharp, it can be dull, but most patients don't have any symptoms. And it's just discovered by imaging. Folks get an ultrasound or a CAT scan or an MRI for another reason, and hey, there's a lot of fat in that liver. And then the list here, fatigue is frequently present. We call fatigue a symptom of life. It's like, who's not tired sometimes? So it's a tough one. But yet fatigue is pretty darn common, especially when the disease advances to cirrhosis. Then the fatigue can be really debilitating. Other incidental findings, incidental abnormal LFTs, or what we call liver function tests. They actually don't measure liver function, by the way. But the common ones here would be the ALT and AST. These are blood tests that pick up proteins released out of liver cells as they're dying. They release the proteins in the bloodstream, so we pick them up on the blood test. So that can be pretty common. The bright liver, that would be on an ultrasound that we see a bright liver, and incidental hepatomegaly. That means an enlarged liver, either on a scan or maybe when your doctor examines your abdomen, they feel the liver edge and think the liver's enlarged. That's hepatomegaly. Some common scenarios where this might happen would be people just getting liver enzymes measured for a variety of reasons. And historically, people got them measured when they were on statins to control cholesterol. We do a lot less of that now because we know that statins really aren't a problem for most people on the liver. And then just regular visits to the doctor, routine insurance checkups. I get folks coming to me who come in with their lab results from an insurance checkup saying, hey, my liver enzymes are elevated, what do I do? But the bottom bullet point here is that we don't routinely screen for fatty liver in primary care. And that gets back to what Wayne was talking about just missing this altogether, which is pretty common. Next slide, please. So what are some of the tests that we can do to try to pick up NASH and the fibrosis of NASH? Because that's what we really want to know, okay? Fatty liver is pretty common, as we already heard, but we really want to know about the NASH. And listed here are a number of the tests, the NIS4. None of these are FDA approved for clinical use. So it's not like you can go to your doctor and order these right now specifically to diagnose NASH. The NIS4 was developed and is being used in clinical trials. You know, the performance of all of these is not perfect by any sense of imagination. And FibroSpect, I don't use that. The ProC3, we use that in trials. And the FAST score is a combination of the findings on the FibroScan. So that's VCTE and the CAP score that we get from that and the AST and the blood test. If we go on to the next slide, it just shows another list of them. Okay, so the ALT is what we commonly measure. That's on routine blood tests that are often measured. And I'll just point out here, one of the challenges when we measure ALT is understanding what normal is. And this has been very frustrating for everybody in medicine because what laboratories report back as normal. So when you get your laboratory report and you see your value, and then there's a range of values, often in parentheses, saying this is normal. The laboratories will report out a population normal most often. You know, they gather up a whole bunch of people and measure their ALT, people who are not known to have liver disease. We did a survey of laboratories that did that. None of those laboratories excluded people with obesity from their quote normal population. So they were actually picking up a lot of people with undiagnosed fatty liver disease, calling it normal. And that's where we see the range of ALT be distorted that the labs report back as supposedly normal. There was a really nice study done a number of years ago out of Italy looking at healthy blood donors and excluding obesity and diabetes. And there they found that men should have an ALT below 30 and women should have an ALT below 19. Anything above that we should be concerned about. And you'll know that if you get your lab results back, that's often not the case. Other tests here include the MRI proton density fat fraction, PDFF. We use that a lot in clinical trials to measure fat, not routinely clinically. And then there's what we call corrected T1. That's another MRI test that really needs to still be validated. The ELF score is to try to detect fibrosis in the liver, and that's a commercial test that's not yet approved in the United States. It's used a lot in Europe. Its performance is still far from perfect, and the ProC3, same thing. So the bottom line here is we still lack effective, cost-effective measures to look at response to therapy or just diagnostically. One of the things I'm doing more of, and it's being done a lot in clinical trials, is what we call FIB-4, FIB-4. And that's just based on the liver enzymes, the ALT and AST, plus your platelet count and your age. So it's really easily calculated. So if you ever want to know what your FIB-4 is, you can just Google that FIB-4, FIB, as in fibrosis 4, the number, and you can plug your numbers into there. And it'll give you an idea. It's pretty good at looking at the lower number. If you're below the lower number, it's pretty good at telling you don't have cirrhosis. So that's how it's best used right now. So if we go into the next slide, talk a little bit about the testing, and this just shows a pyramid looking at risk of NASH based on clinical factors. And as experienced clinicians, we often just do this in our head. So you see the high point of the pyramid, the high likelihood of NASH and fibrosis in the darker blue, and that's the high at the top row on that little table there. So that's the folks who are older, and older here meaning greater than 50, and folks who have type 2 diabetes, not type 1, it's only type 2, obesity, hypertension, and then the FibroScan liver stiffness measurement over 8.5 kilopascals, elevated AST, NAFLD fibrosis score. Folks who have all that, very concerning for advanced fibrosis. That'd be a stage 3, one stage less than cirrhosis, or stage 4, which is cirrhosis. Now on the bottom line, you can see the opposite end of the spectrum. The younger person who's not diabetic, not obese, and all the testing looks okay. Very low probability of NASH with advanced fibrosis. So clinically, that's what we're doing now. But we still need, it would be nice to have tests, blood tests, where we could really narrow this down better. Next slide. So in the, I'll go over 3 abstracts that were looked at in the, and were presented at the meetings. And just very briefly, I'll go over them because I don't think they're huge advances in the field. This first one is a study that looks at the optimal electronic health records. And this is a huge insurance database of hundreds of thousands of people. And they looked at fast progressors and intermediate progressors and slower progressors, or what they call here standard progressors, and tried to sort out, because we do know some people progress very fast. And that's why we have pediatric patients. I don't follow children, but my colleagues who do see the patients who are cirrhotic in their teenage years from NASH. So it's pretty scary. But cut to the chase here, the conclusions is that they were able to identify those with different progression rates. And they developed an algorithm to try to do that. We really need to understand the genetic underpinnings and other exposures that would predict that as well. We go on to the next slide. This is I think the next 2 are both machine learning models. So this is using computers to analyze a large amount of data. Historically, when I talked about those other scores, we've taken different laboratory values that sort of made sense and smushed them together to develop a score. But now there's a lot of effort to let the computers do that and take hundreds or thousands of data points, different measures, and analyze them in a lot of different ways to see if the computer can figure out a nice way to run that. And so this is just the bottom line for this particular abstract, was that there was some benefit to them doing that. I must say there's still a lot of assumptions that go into this type of analysis of how the computers actually analyze the data that, in my mind, are a problem. The next slide. So the take-home points here is that we need non-invasive tests. If we can avoid the biopsy in most circumstances, that would be a huge advance. The ALT and the AST are not sensitive for NAFLD, but I wanted to highlight on that particular point another abstract that was presented at the meeting that I did here, which was really nice. They looked at the AST to ALT ratio. So when you get your blood tests back, usually with NASH, the ALT number is greater than the AST. When the AST is greater than the ALT, then we worry about more advanced NASH. Or we also clinically worry about drinking too much alcohol. So we see that in some patients as well. But most folks with NASH, that's not the issue that we're concerned about. So this was a huge population study in Wales in the UK. And it looked pretty good. That's a simple thing that clinicians can do. And another one on the second bullet is the FIB4 that I mentioned, which I think is pretty useful. Those are the take-home points from here, but I will mention, finally, one last session I went to that was very enlightening was on what we call precision medicine or personalized medicine, really trying to hone down what are the genetic risk factors for people, individuals with NASH, because our general feeling is patients do not get to NASH all by the same route. And this has implications for testing and treatment. That's Dr. Friedman will talk about. Because one of the implications for treatment is likely means different treatments would work very differently in different patients. And as far as testing, there might be perfect tests for one subcategory of NASH that doesn't work well at all in the other category. And all these analyses I just showed you, they lump everybody together. So I think that is the future, where we really need to do a lot of work to understand those differences and really separate people out into different groups. I could talk for a long time on that, but I think my time is up. So thanks for your attention and thanks for joining the webinar today. Hope you're finding it useful. We'll move on to Dr. Friedman now.
Dr. Tetri, thanks so much. I just have one quick question and then we'll open in the end as well. So, biopsy has been the gold standard for staging. And, with our friends at the Global Liver Institute who've launched the Beyond the Biopsy campaign, there's much more attention to non-invasive tests. So if someone, based on, they may be overweight or were told, maybe you should check this out, your liver, would you recommend that they ask for when they go see their primary care physician, not at the level of a hepatologist, but just on their annual checkup or something like that?
Well, as part of the annual checkup, people are often getting their liver enzymes, AST and ALT, measured. And frankly, it'll be beyond the skill set of primary care physicians, despite our efforts to educate them, to calculate the FIB4 and just look at the AST-ALT ratio. But those are things that could be done. But other than that, frankly, I don't find ultrasound that useful in my practice because too much fat in the liver is seen in about a third of the population. So in ultrasound is relatively insensitive. It'll pick up a large batch of that, but not all of it. So I think we need to look at the blood tests. And hopefully we'll get some of these other blood tests coming out in the future that will be better at detecting NASH based on the fats or the lipids in the bloodstream or some proteins in the bloodstream or a combination of that, but we're not there yet.
And is there any hope that we can get the laboratories to do a FIB4 calculation as part of delivering the results?
I think it's a great idea because already laboratories are providing us measures of kidney function, for example, based on a lot of factors, including the creatinine level, but they put other factors into that. So on our laboratory reports, we see estimated glomerular filtration rate, which is a better measure of kidney function than just the creatinine level. And they could easily do the same thing, calculate a FIB4, if there's a platelet count in addition to the liver enzymes, which is as an aside, my endocrinology colleagues often don't measure the complete blood count, so they don't get a platelet count, which is interesting.
That's excellent. That's something we can certainly talk about advocating for. So with that, our last speaker is Dr. Scott Friedman. He's the Professor of Medicine, the Dean of Therapeutic Discovery, and Chief of Division of Liver Diseases at Icahn School of Medicine at Mount Sinai. So Dr. Friedman is going to talk about treatment as presented at the conference. Over to you, Dr. Friedman.
Thank you, Neeraj, and thanks to my colleagues, and most importantly, thanks to Wayne for his passion. There is no question that patient engagement and advocacy makes a huge difference in all forms of healthcare, and that's equally true in liver disease. So having the patient voice and the patient input is so vital, and not only do we listen to it, but it turns out legislators and decision makers in all spheres listen to patients. So keep up the great work, Wayne. I hope your program continues to grow, and it's been a pleasure to work with you over the years. Before I start my talk, I'll address one question about FIB4 calculation. So we actually have implemented automatic FIB4 calculation through our electronic medical record. So anytime the appropriate tests are ordered, it automatically provides it to our practitioners. And the reason really speaks in part to Dr. Gunn's comments as well as the opening comments, which is that we are missing the vast majority of patients with fatty liver disease, and particularly NASH, because patients rarely have liver-specific symptoms. And in fact, there was a study at the liver meetings last week in the European liver meetings, similar to one we've done and others, that if you specifically look at any patient with type 2 or population of patients with type 2 diabetes, probably up to 65 to 75% of those patients will have some degree of fat or abnormality in their liver. So I think one of the lessons is that for diabetologists or other clinicians who manage patients with diabetes, they shouldn't wait to look for NASH. They should screen for NASH for sure in type 2 diabetics, but really look beyond that to think about it in all patients. So part of it is patient education. One of the challenges, of course, is we don't have any approved therapies, just diet and exercise, which are, as we've alluded to, very effective. But without something to offer the patient in the event that the diagnosis is made, there's been some reluctance, particularly on the part of public health agencies, to establish broad screening programs, since if we're going to go around and screen for patients, unless we have something to provide them, all we're doing is raising anxiety or advising weight loss and diet. And I predict that the minute that the first drug is approved, which I think will happen in the next couple of years, the minute that the first drug is approved, there will be a much more concerted effort to go and find patients who don't realize they have NASH, but who might be candidates to benefit from therapies. So let me dive into some of the comments and underscore the fact that we don't have any approved drugs for NAFLD or NASH, but there is intense activity in all phases of drug development, starting with ideas, new molecules, animal models, and then the more familiar phases 1, 2, and 3 trials that progressively test with greater stringency the potential of a drug to benefit NASH. I also want to thank the attendees for so many great questions. My fingers were burning trying to type replies. I can't do it while I speak. I'm not that talented. So hopefully my colleagues will pick it up, or we'll answer a few more questions at the end. So next slide, please. I work with a lot of companies. My comments today are obviously not influenced by those relationships, but it's actually a very exciting part of my career to actually apply what we've been doing in the laboratory towards the design and testing of new therapies for NASH, and those companies are listed here. Next slide. So I think we've heard about weight loss and the importance of lifestyle, and I'll say something that isn't really controversial, but needs to be restated. If you were to make a graph or a grid and look at all the different candidate therapies and all the different effects we would like those ideal drugs to, or those drugs to ideally accomplish, the only one that checks all the boxes is weight loss. And so I can't emphasize enough how important even modest weight loss, we're not talking about 20%, we're talking about 5 to 10 pounds can really make a difference in the metabolism. And so weight loss has to be the mainstay. Now the challenge, and one that I face every day myself, is it's a lot easier to lose weight than to keep weight off. And for now, the long-term success of weight loss programs is somewhere around 5 to 10%. That doesn't mean one shouldn't focus on weight loss. It has to be viewed, as Dr. Tetri said, as a long-term lifestyle choice, not as a, gee, I'm going to lose 20 pounds in order to get ready for a wedding or an event. It has to be, as Wayne has done in his life, make a full tilt readjustment, shall we say, in terms of lifestyle and exercise. And exercise is also very important, not only for cardiovascular health, which is a risk in patients with NASH, but also because it improves insulin and glucose homeostasis and has a lot of beneficial effects. In addition, where we are now is to reduce the risk of cardiovascular disease, and those include drugs for type 2 diabetes, as well as hyperlipidemia and high blood pressure, all of which are more common among patients with NASH. And so now we're moving towards liver-directed therapy. The list of available drugs, as you can see, is woefully short. Vitamin E has some benefit, we think, because it blocks oxidant stress, as well as pioglitazone, which is a kind of actually primarily a diabetes medication. The challenge with pio has been that while it actually improves the metabolism, most patients gain a few pounds, and that seems counterintuitive if you're trying to motivate patients to take their medicines. Next slide, please. So there are drugs available, and these are approved drugs, but they're not approved specifically for the treatment of NASH, and that's why it says here off-label. There are therapies, I mentioned pioglitazone, there's also metformin and liraglutide. I'm not going to go through the details on this, but none of them are indicated primarily to treat liver disease. They're indicated to treat type 2 diabetes. I've already mentioned vitamin E as an antioxidant. There's one trial, and there's actually a very interesting retrospective study from the University of Indiana that suggests that patients who took vitamin E long-term may have had better outcomes in liver disease. But it's been a challenge to introduce vitamin E under routine practice, and it's also worth remembering that vitamin E is not a pharmaceutical, it's an over-the-counter supplement, and those kinds of supplements are not quality controlled to anywhere near the same extent as FDA-approved prescription meds. And so one of the challenges of advising vitamin E is that we can't really be sure that the activity is comparable across different preparations that you might buy in a pharmacy or a nutrition store. And nonetheless, there's no argument to be made against vitamin E, particularly in patients who are non-diabetic, who don't have diabetes. There's a little higher concern among patients with diabetes. And so the current recommendation is very little harm, but probably the benefit is not enough to really solve the problem of NASH. Next slide, please. This slide, which replicates the phases of disease that I think Wayne introduced, is really just intended to give hope to all of you who are worried about your own health or those of loved ones, to give you hope that there's an awful lot in the pipeline. And that's certainly, someone asked me, a consultant or actually a medical news writer asked me, well, what's happened to NASH in the midst of the COVID pandemic? And I said, NASH was here before COVID-19 and NASH will be here after COVID-19. And to my experience, the last 4 or 5 months haven't slowed in any way the urgency to get to newer treatments for this, for NASH. So I would be assured that the push to identify better and newer drugs and ones that will reach FDA approval is as intense as it has ever been. Next slide, please. So I'm just going to review very briefly a couple of therapies that were presented at the European liver meetings, not because they're necessarily the most promising, but they just give you a flavor for the kinds of approaches and the kinds of endpoints that we're looking at vis-a-vis what Dr. Tetri had said earlier about how to diagnose NASH. And so one of the more interesting drugs is something called aldafermin, which is from a company, NGM. Full disclosure, I've consulted for them in the past, but not in the last 2 or 3 years. This is a specialized kind of engineered molecule that in some ways mimics the effects of a native hormone known as FGF, or fibroblast growth factor 19, with a very special modification that prevents it from inducing pathways that might lead to liver cancer. So it's a safe drug as best we know. And it, in a 12-week trial, there was astounding results that were really amazing, because the company did biopsies in patients at the beginning of the trial and only 12 weeks later, which is highly unusual. And this was a follow-up study to say, okay, it worked at 12 weeks, what about 24 weeks? And that was the purpose of the study. The study criteria are listed here. They were fairly standard for the kinds of patient populations we're testing who have NASH. Next slide, please. And the short answer is that the effects, the benefits that we're seeing at 12 weeks were sustained and perhaps even a little more favorable at 24 weeks. There were significant reductions in liver fat. We generally know that fat per se doesn't necessarily confer risk, and most patients with non-alcoholic fatty liver disease have fat with no inflammation and fibrosis. That's often called NAFLD. But in those patients who also have inflammation and scarring and ballooning of hepatocytes, or NASH, the less liver fat, or the more you can reduce liver fat, the more promising it will be in improving other features of the biopsy, like the inflammation and the scarring as well. And what you can see here is that there were clearly improvements at 24 weeks in AST and ALT, which are liver enzymes, as well as fibrogenesis markers. And it was very well tolerated. It is a daily injectable, and so that's not optimal. You don't want to have to require patients to inject a sub-Q every day. On the other hand, if it really is potent, that may be a price worth paying for patients who are, and for their providers who are concerned about their long-term outcomes. And so what you can see is you're comparing on the right-hand side placebo to the drug aldafermin, and the significance, meaning the statistical likelihood that the drug is having an appropriate benefit, are shown on the right-hand side. They're all very significant, and they all show that there was a marked reduction in liver fat, and that's a good sign that the drug will also improve other features of NASH, and in fact, there were improvements in fibrosis and NASH histology. So it tells us what worked at 12 weeks now works at 24 weeks. Remember, NASH is a marathon, or treatment of NASH is a marathon, not a sprint. And so while we're excited when we see results at 12 and 24 weeks, what we really want to know is, does that eventuate into the kinds of improvements that Wayne showed in his liver biopsy, which is a meaningful long-term benefit in terms of the scarring and the other features of NASH under the microscope. Next slide, please. And I see in the corner of my eye a question which is appropriate to answer now. Can NASH be reversed and the liver will go back to, will the liver go back to normal? And there's no question NASH is reversible. The question is how severe, that we don't we can't answer yet is how severe can the NASH still be before it's not as reversible? And we think anything short of cirrhosis is virtually always reversible. Among patients who have cirrhosis, some may reverse and some may not. We don't know which features predict reversal, but certainly the goal here is to prevent people from progressing to the point where they get advanced scarring or cirrhosis. So the short answer is NASH can be reversed. Now, one point I'll make, which is that even in that aldafermin trial that I just showed you, only 30 or 38% of the patients had a significant benefit. So that leaves the majority of patients who didn't benefit from this therapy. And it speaks to the idea that maybe we need to hit more than one target at a time. And that's what the trial with cotadutide sought to address by combining two different mechanisms or targets that together may have more of a benefit than either one alone. One is called the GLP-1 agonist, and the other is a drug called glucagon, which mimics a natural hormone called glucagon. And the easiest way to think about glucagon is it's effectively the opposite of insulin. And so the thought was that this would be a benefit of to a greater extent than either component alone. This was a 54-week trial in type 2 diabetics and was based on non-invasive markers, some of which you heard about from Dr. Tetri, as well as body weight, AST, ALT, as well as NAFLD fibrosis score and fatty liver index, as well as a non-invasive marker, PRO-C3. Next slide. And so just to summarize, there was promising news, reductions in body weight, which, as I said, is extremely important. I think Dr. Gunn also emphasized how important that is. Some reductions in the liver tests, as well as the NAFLD fibrosis score, which is a calculated score that correlates somewhat with fibrosis, as well as a fatty liver index. So these are promising. I think one thing to keep in mind is both the trials I described are so-called phase 2 trials. That means they're tested in generally a couple of hundred patients. And if promising, the company and the FDA may agree to move on to a definitive trial known as a phase 3 trial, which with much larger numbers, typically several hundred or thousands of patients, to really establish in a large enough number of patients whether the drug is reliably effective. And so what I'll say about cotadutide is that the results look promising, but not definitive, in part because this did not include liver biopsy, which is considered the gold standard. Okay, next slide. I think that may be it. Is that right, Henry?
Yes.
Yeah, okay. So I think that leaves us time for panel questions. They're piling up on the right-hand side as well. And I guess, Neeraj, you'll be moderating these as best you can. And I want to, again, close by thanking Wayne, Neeraj, and Henry, as well as all the attendees who are asking wonderful questions and really committed to making progress in this field, as well as my good colleagues, Drs. Tetri and Gunn.
Excellent, Dr. Friedman. Always a pleasure to hear you present, which reminds me when I heard a presentation of yours, I think it was last year at Georgetown University, and you said that OCA, which was a potential drug, was something that probably would have been approved by the FDA. And I you know, for many reasons, one of which was it wasn't approved, one of which was the understanding of the endpoint of it. And could you elaborate for our patient community what is meant by an endpoint, and if there's any potential for patients to be involved in getting a consensus or what would be acceptable for them as an endpoint?
Yeah, so it's a great question, Neeraj. The final word has by no means been issued around obeticholic acid. And I think that the FDA was a little opaque, and I've been pretty public in saying that the way this was handled by the FDA, let's just say, was not optimal in terms of having a specialized committee scheduled and then not reviewing necessarily all the data that was available to them. And I know that the company is really committed to proving the value of their drug. And I will say there were a number of presentations at the Digital EASL or ILC meeting last week that reinforced the activity and benefit of obeticholic acid in NASH. So I don't think the final word has been issued yet. In terms of endpoints, you know, basically the phase 3 drugs or phase 3 trials in NASH right now are predicated on showing an improvement in fibrosis more than anything else. And that's been something we've evolved towards, because it used to be we were trying to show a benefit in the inflammation and the cell death and the fat. But it turns out that the one thing that really predicts whether patients are going to get into trouble is whether or not you improve their fibrosis. So, and frankly, that personally, that's gratifying, because I've been studying fibrosis since the early 1980s. And it's something we understand well. So the end point for all these phase 3 trials, among others, is to show that if it's beneficial, that the scarring intensity should go down while the NASH stays quiet. And it's worth keeping in mind that that's what might be called a registrational or approvable endpoint. But in the end, patients don't feel any different and don't necessarily have different outcomes if their fibrosis improves. And so any drug that's going to be approved for NASH in this way, the FDA will appropriately require the company to say, well, it's great that you improve the fibrosis, we'll approve the drug, but what we really want to know is, in 5 years, are those patients who had an improvement in fibrosis developing less cirrhosis, less liver failure, less liver cancer? Those are going to be the long-term endpoints that establish long-term efficacy of a drug. But for the purpose of FDA approval right now, the biopsy evidence of improvement in scarring is going to be the most important readout to determine efficacy.
Excellent. I want to take advantage of the fact that all three of you are clinicians as well and see patients. And so 2 questions related to that. One is, if someone is diagnosed with NASH or NAFLD and they are committed to their well-being, but also moving the field forward, what advice would you give them on clinical trial enrollment? Should they play a role? So that's one. And the second is, with the presence of comorbid illness, whatever it might be, autoimmune disease or a headache, and taking acetaminophen or anything that's metabolized in the liver, how should they be cautious with their lives with other medical conditions?
I'll take, you want to take all of us can weigh in on this, because these are conversations we have regularly with our patients. And, you know, just about every medication, almost every medication we take is metabolized by the liver. When the liver has NASH, the metabolism is not modified much, but if it's progressed to the point of cirrhosis, the metabolism is slowed for many drugs and medications. So we have to be careful with that. The medications I counsel my patients to be careful with, of course, is acetaminophen or Tylenol. And as hepatologists, we're actually okay with up to 4 tablets or up to 2,000 milligrams a day. We never see liver damage with that much. So, you know, if for the occasional headache or whatever, it's just fine. You know, just avoid taking many more than that, because then we could run into liver damage. Anybody else want to weigh in some more?
I want to weigh in on something I failed to answer from your first question, Neeraj, and that was, can patients play a difference in the drug approval process? Mm-hmm. And the answer is, you bet. You know, Wayne took the initiative, I know, in articulating on the behalf of patients that he and they were disappointed in the FDA's handling of the obeticholic acid review. We're here for patients. That's it. And so, if patients feel for any reason they're being shortchanged in the process or in the outcomes, they need to be part of the conversation. And again, I applaud Wayne and you, Neeraj, and Henry for recognizing that. The more patients speak up in the appropriate ways, the more we can affect change. And obviously, working hand in glove with physicians or healthcare professionals can only benefit all.
That's great. There's one.
Neeraj, I just want to weigh in to emphasize the point of the importance of participating in clinical trials. Mm-hmm. When you think of every single medication that we take, antibiotics, whatever, they have all been tested in people, in volunteers, in clinical trials. So it's other people that have taken potential risks, but we benefit from it. So when we participate as individuals in a clinical trial, the benefit may not accrue to us. There's a chance we could benefit, but the benefit accrues to other people in the future That's how we get treatments approved. That's how we benefit other people.
Absolutely. So it's a public good. There's one more question I want to have.
There are one other point for patients. It is occasionally, if a drug turns out to be effective, and there have been some circumstances where the drug was so effective they stopped the trial, it's not unusual that the company will then offer the drug to everybody, particularly if it's approved. So there could be personal benefit beyond the extraordinary contribution that comes to doing clinical trials for patients.
And I also like to tell my patients to consider clinical trials as an extension of their care, because oftentimes when they feel like they've hit a roadblock with their gastroenterologist or hepatologist because there's really not much we can offer them. But then if they look to a clinical trial, they now have an opportunity to be on something that could curtail the disease.
Great point.
And even if a drug is not approved, they can get special permission to use it. Absolutely. There was one more interesting question I want to ask, and then we need to start wrapping up with Wayne's concluding comments, which is, so we do all these interventions, but might there be an underlying genetic condition, whether it's the metabolism of fats or cholesterol, that predisposes people to developing fatty liver disease?
So this is a really important question, Neeraj. It's known, for example, that in individuals who have NASH, advanced NASH, there's a 70% chance of NASH among their first-degree relatives. That speaks primarily to the shared genetics and the genetic risks, which is more and more being pursued to uncover reasons. It may also tell us that not everybody who has NASH got there in quite the same way. Some may have certain genetic predispositions more than others. One other implication of the first-degree relative data I told you is that the other component we haven't talked about is that first-degree relatives typically share the same microbiome. And so because they live often in the same home, they tend to share the same bacterial makeup in their colon, and there's increasing evidence that suggests the microbiome could be a very important driver of the presence or severity of NASH. So a lot is being done around the genetics of NASH. None of that has really changed new drugs, but some of the genes that are coming up on these genetic studies are slowly but surely making their way towards developing new treatments.
Okay, excellent. Well, I want to be cognizant of time. I want to thank you for all your presentations, and Wayne will give the concluding remarks. Just from a logistics point of view, we will try and do a frequently asked questions or responses with our panels and post it up on our site as well. Thank you so much, and Wayne, over to you.
Well, thank you, Neeraj, and wow, thank you for our experts here. This has been a very interesting session. I appreciate very much the time and talent that you've shared with us and with our listeners. This was supported by grants from Intercept and NetNoggin, and we're very appreciative to that. And we will be publishing this as a link to Facebook and YouTube. So it will be available to be shared with other friends and other people that you think might benefit from it. And we will be, this is the first of a series. We plan to do this again at AASLD, and to do it as important conferences come along, and this will become part of the patient education and outreach archival work that the Fatty Liver Foundation will be doing. And with that, we'll sign off, and thank you very much for your time.
Thank you.